Assalamualaikum. I'm Dr. Maham Khalid, the co-director of the academic wing of Ventilators of Pakistan, and I welcome you all to the 7th session of our COVEB series, where we will be shedding some light on the obstetric and gynecological concerns of COVID. This is part of the educational activities taken up by the academic team at Ventilators for Pakistan. Ventilators for Pakistan has become a name of its own, not just due to the amazing vision of its founders, Dr. Sabai Akhtar and Dr. Rabiz Tariq, but also due to the unrelenting efforts of all of its team members. This week, we would like to talk about the amazing work being done by our internship team. The internship program has been running in collaboration with Shifa for You and Smart Clinics. They inducted 40 students from all over Pakistan to train them on EMR. They learned things like scheduling appointments, adding patients to the smart portal, creating and editing notes, creating prescriptions, and many other things. The 40 interns completed 5 online seminars, 5 dummy cases, and 2-part final assessment. Some of the outstanding interns include Hamza Iqbal, Haider Asim, Safa Iqbal, Ayman Zafar, Maham Ansar Javed, and Moeed Altaf. On the 13th of August 2020, VFP internship program officially closed with 40 graduates. Dates for the second batch will be announced soon. Over the weeks, we will try to share all the efforts that VFP has been making to combat this deadly disease and its effects. The force behind this groundbreaking work was headed by Dr. Warda Ajmal, who is the director of the internship series, and the members include Dr. Bakhtawer Mirza, Dr. Hamna Ahmed, Dr. Arshia Akbar, Dr. Aisha Ahmed Khan, Dr. Mariam Ahmed Khan, and Ms. Warda Tariq. Thank you so much for all of your efforts. Now, without further ado, I would like to introduce my co-host for the evening, Mr. Ibrahim Majid. Ibrahim, over to you.
Thank you, Dr. Maham. Assalamu alaikum. It is an honor to co-host the COVEB educational series. I'm a member of the academic team for VFP, and I would like to talk a little bit about our affiliate, the Yardim Foundation. Our co-director for education, Dr. Mavish Erkin, along with her sister, Ms. Maham Erkin, founded this organization a little over a year ago with the intention of providing help to the marginalized sections of our nation. It currently has 3 running programs. The Yardim Dental Program, under which they organize free dental camps and provide free dental treatments to the underprivileged communities. The Mental Health Awareness Campaign, to help tackle the stigma in our society while also providing information and support to people suffering from mental disorders and illnesses. And lastly, the FRP, which is the Food and Ration Program. We thank Team Yardim for all their efforts in co-organizing this series. Now, I would like to mention some personalities without whom this web series would not be possible. The patron-in-chief for this series is Professor Emeritus Lieutenant General Mahmood Ahmed Akhtar, who is Hilal-e-Imtiaz military. And our patron is Professor Dr. Samia Naeemullah, who is a recipient of the President of Pakistan Gold Medal by the Pakistan Pediatric Association. Thank you, ma'am and sir, for your support. I would also like to take this opportunity to particularly thank Rawalpindi Medical University, which has accredited these educational series for all of you to enjoy. Thank you to the Vice Chancellor and the medical education team of RMU. Over to you, Dr. Maham.
Thank you, Ibrahim. Now, with a lot of pleasure, I would like to welcome our first speaker for the night, the esteemed Professor Rizwana Chaudri, who is a professor of gynecology and obstetrics and a very well-known personality with many feathers in her cap. Dr. Rizwana graduated in 1983 from Rawalpindi Medical College, now Rawalpindi Medical University, as the best graduate of the year. In fact, she held the honorable title of being the best of the best graduates of 25 years at RMC. She secured first position in Punjab University in all the 4 professional examinations, along with the distinction in 5 subjects. She was also the recipient of the Pride Performance Award and 13 gold medals. In addition to a very commendable and high academic record, Professor Rizwana also remained girls table tennis champion and captain for 5 years. She was the best English and Urdu debater at RMC and has since also completed a diploma in oil painting. Professor Rizwana has worked very enthusiastically for improvement in maternal mortality and morbidity in Pakistan. She previously served as elected councillor of the College of Physicians and Surgeons of Pakistan for 3 terms and worked as a regional director of the Islamabad Center for 10 years. She was also the ex-chair SOGP Rawalpindi Islamabad chapter and recently retired as a dean and head of Department of Gynaecology at Rawalpindi Medical University. Professor Rizwana is also actively involved in research and has published and presented numerous papers in national and international journals and conferences. She has served as editor-in-chief of a quarterly journal of Obs and Gynae Society of Pakistan and is the Pakistani coordinator of a large world woman trial for postpartum hemorrhage, which is a leading cause of maternal mortality. She published in The Lancet in 2017, and now after the trial, tranexamic acid is included in the guidelines of PPH management by the WHO. She has also started a collaborating center with the London School of Hygiene and Tropical Medicine and is doing world-class research, Woman 2, in another, which is another major clinical trial with this collaboration. She's extremely loved by all her students, and there are very few people who match her caliber. Quite commendably, in spite of being one of the best students and doctors of her time, she never availed any opportunity to settle abroad, which came her way many times. She's a very patriotic Pakistani who wants to stay in Pakistan and serve the people of Pakistan. Without further ado, please allow me to welcome Professor Rizwana Chaudri. Ma'am, over to you.
Thank you very much, Maham, for such an elaborate introduction. I'm really overwhelmed. Thank you. And today I was asked to talk about the OBGYN services during the pandemic. I think this is a very, very important topic, and it is important for the people of Pakistan. It is important for the health professionals of Pakistan. So everybody knows about it. I mean, at least the doctors and everybody, this has been talked about to such an extent, but still I would just go through it a bit quickly, that it's called the SARS-CoV-2, and SARS stands for Severe Acute Respiratory Syndrome. And this is the second of the series, so it is number 2, and it was diagnosed for the first time in Wuhan, China in December 2019. That is why the data is constantly being reviewed, collected, changed. The guidelines are being changed. So there's nothing which stands absolutely correct as to this day. So the WHO declared this as a global health emergency in January 30th, 2020. The mean incubation period of this is 5 days, but it ranges between 0 to 24 days. And it's called the coronavirus because the structure looks like a crown, as you can see over here. And this is the anatomical shape. And the interesting thing is this, that in the first week, you get the PCR positive, and it may decline in the second week, and it may become negative if you do this test in the second week. And the PCR is done either from the throat swab or from the nasopharyngeal swab. And at about the 7th day of the disease, IgM antibodies, they appear in the blood, and this is diagnosed with the blood tests. So IgM, however, then reduces by about the 3rd or the 4th week of the disease, whereas it is taken over by IgG antibodies, and these IgG antibodies actually provide immunity to a person. Now, the thing is this, that IgG antibodies, for how long they remain in the body, it's different in different individuals. And there is no set criteria which would say that this person will have an IgG antibodies for the rest of his life, or he would have it for a month or 3 months, etc. And that is really, really important, because then that gives you the immunity towards a reinfection with COVID-19. But things are not very clear at the moment, although cases of reinfection have also been shown. And the transmission routes are directly, and it's mostly spread directly from the respiratory secretions, which enter either through the eyes, nose, mouth, or airways of the person, of the recipient who gets the disease then. Indirectly, by touching any surface or object on which the hands were laid by an infected person, and then you touch it and you touch your nose, mouth, eyes, and you can have the disease. It has also been isolated from the peritoneal fluid, feces, fomites. Whether this is transmitted through the sexual route or not, there is no evidence so far. So there are varied clinical presentations. The person may be totally asymptomatic, or the person may have one of these features. Usually cough, fever. They are present in majority of the people, especially fever. But considering all these, diarrhea or vomiting may be the only symptom with which the patient comes. And sometimes it is just anosmia, that is loss of smell or taste, with which the patient presents. So there are different variable presentations. 1 or 2 cases have also been reported isolated as meningitis. One of them was a medical student of Lahore, and his parents were also doctors, and he was finally diagnosed as a case of meningitis, and he died of that, unfortunately. So you have a case which has no suspicion even of COVID. Then you have suspect cases, and then you have confirmed cases. So suspect cases obviously depends upon one of the epidemiological criteria, and the confirmed cases are those in which the laboratory test shows that the PCR is positive, irrespective whether they have the signs or symptoms or not. Now, I mean, is it different in pregnant patients as compared to non-pregnant patients? Is it different in males as compared to in the females, etc.? These are questions which require answer, and which maybe after a long, long time we may have different answers to these. But at the moment, the disease severity of pregnancy is comparable to the non-pregnant adults. And it may be totally asymptomatic. It may have very, very mild symptoms, or the symptoms may be little moderate, such as fever, cough, there may be shortness of breath. There's extreme weakness in this condition usually. Whereas the severe disease would have severe respiratory distress, pneumonia, hypoxia, and severe anorexia. And there is a lot of weakness which the patient feels. So, and in these cases, obviously, the maternal mortality can be high, because resuscitation of a serious patient with a baby inside may become a problem in a number of cases, especially if the baby is more than 24 weeks size. So there are different effects, but I think Dr. Shahnaz is going to talk about them, so I'm not going to say anything. So then vertical transmission. Whether vertical transmission occurs or it doesn't occur is still not clear, but most of the literature probably goes in evidence of the vertical transmission is not there. However, 2 infants who were born to COVID-19 positive mothers were found to have IgM in their serum, and IgM antibodies do not cross the placenta. That means that their own IgM antibodies were formed. But probably there is no vertical transmission. Now, so what should a pregnant patient do? If she is not a case of COVID, or if she is a case of COVID, she may be asymptomatic, mild, moderate, severe, but she's COVID positive. And the others are who are not COVID, and they do not even have an epidemiological factor which shows that they may be positive. So then what should they do? The thing is this is a normal antenatal care model, which was the WHO model. And before that, it was said that even if 4 visits are done, 1 in the first trimester, the second in the second trimester, and 2 visits in the third trimester, these are the minimum visits which any pregnant woman should do to reduce the maternal as well as the perinatal mortality. However, then this was reverted to 8 visits. And 8 visits were first up till 12 weeks, that is in the first trimester, then 2 visits in the second trimester, and 5 visits in the third trimester, which is an important trimester in which most of the complications occur if they have to. So what should a pregnant woman do? There was a lot of chaos when there was a lockdown in Pakistan. I mean, people who were pregnant at that time, they just didn't know what to do. People themselves were afraid of going to the hospitals, and the doctors were afraid of seeing patients who did not have any complaints. And these pregnant women who come for normal antenatal care, obviously most of them would be without complaints. It's just a normal routine antenatal checkup. So what should you do? The thing is this, that the routine antenatal care should continue. But how should it continue? It is much better that one-to-one contact is not there physically. So if the patient does not have a problem, then the best methodology would be to have a teleconferencing, to have a WhatsApp message, to have a WhatsApp video call, all different sorts of, because nowadays the technology is so advanced that you can do that. But then you need dedicated personnel from the hospital who should be doing this. And they should be good enough to detect things just by seeing the patient or just by hearing the complaints or seeing the patients. Otherwise, if it is necessary that the woman comes to the hospital, then it is important that the staff should be well protected, and all the patients and the visitors should wear face masks, at least the surgical masks, and arrangements should be in the OPD to ensure social distancing, that is, they should be sitting far apart. Whereas in our government hospitals, if you open up the outpatients, there's such a lot of crowd, especially in the OBGYN department, that maintaining the social distancing in the space which is available becomes really difficult. So it is important that only those patients come to the hospital who are actually in need of visiting the hospital, and the others should be managed by teleconferencing, video conferencing, by electronic records. Then there should be self-care by the patient as well. So they should be taught something, and that also has to be done by these different methodology. So then antenatal visits, if they are missed and now the pandemic is slightly going down, when the lockdowns are finished, then they can be readjusted according to the problems which the woman or the fetus faces. Vaccination, I mean, we give tetanus vaccination to women of our country because all of them may have not been vaccinated for tetanus, and you don't know where they are going to deliver. So to prevent the tetanus of the neonate, especially, and even of the mother, you have to give the doses, so they must be given. Even though you are doing teleconferencing, they should be advised what to do. Then there can be, obviously, that is why, even if you're not having any problem with your pregnancy, even then it is proposed that at least 8 visits, at least, are necessary. So why do you say that? Because all pregnancies, I would say, are low-risk pregnancies. There is no pregnancy which is no risk. You may not be having any problem, but you may develop a problem during pregnancy. And you may even die of that problem during pregnancy, especially in countries like ours, where the facilities are far apart, where the people live very far away from the proper facilities where ICU care or where antenatal care can be provided to the complicated cases. So you have to be very, very careful. If a patient develops blood pressure during pregnancy, if a patient, so that has to be seen, obviously. So there is a difference between a patient whom you are seeing, whether that patient is educated enough to monitor her own blood pressure, to monitor her blood glucose levels, to get her investigations done, or the patients you are seeing are uneducated patients. You may have to call them to the hospital. So then gestational diabetes may have many risks, especially for the fetus, but even for the mother. So you have to call these mothers for the antenatal care. So while you are discussing this, you must discuss healthy diet, daily rest, the intake of iron, because about 51% of our population has iron deficiency anemia, although we have a very high incidence of thalassemia trait as well, but majority of they are iron deficiency. So good nutrients or multi-micronutrient uptake should be taken. Another very important thing is that while you are doing the antenatal care, you must discuss family planning services also with them. because this is one thing which is lagging behind during the COVID pandemic. And this is really going to kill a lot of women just because of unplanned pregnancies, having induced abortions, having complications of pregnancies, not going to the doctors, etc., etc. So I think family planning services should be an integral part of the antenatal care, whether you're doing it on the telemedicine. You must discuss with them, you must advise them what they should do as soon as they deliver. Then self-care intervention during and after pregnancy should be encouraged, especially during self-isolation. So what if you have to call a person to the hospital, or the person thinks that that person needs to come to the hospital? What is important in every hospital, that there should be a triage before they enter into the clinic, into the proper area of clinic or the hospital. And the person sitting in the triage should have a complete protective instrument with the person. So you need to take the history, and you do need to do a certain quick examinations, such as checking of fever, cough, etc., or any suspect whether there was COVID at home, COVID in the very close community, she has traveled, etc. So if she is found to be high risk, then she should go towards a specifically dedicated COVID unit. Whereas if she's low risk, then she can go to the routine care of OPD, emergency, labor room, OTs, etc. The problem with our specialty is this, that you really, it's very difficult to assess if the patient says she's having leakage. Probably you will have to see her, that whether she has ruptured her membranes or not. If the patient says she's having very less fetal movements, you will have to assess her. So the thing is this, that you may have to call a number of patients in, still just listening to their complaints. But you have to be careful while they are in the hospital, to save them from other patients who may be carriers or who may be positive, and to save yourself and all the healthcare professionals. So those people who are having symptoms, they should be designated, they should go to certain designated areas of the hospital. In every hospital, there should be designated areas where COVID suspects are taken. Once confirmed, then they can be referred to appropriate places where they belong. So after 32 weeks, it's very, very important that if the patient develops COVID and she's more than 32 weeks of gestation, then they should go to specialized clinics to be looked after properly. So what about antenatal care for suspected or confirmed cases? If they are having mild symptoms, they talk to you on the telephone, they're having symptoms, they have not had COVID, but they are suspected to have COVID, then what should you do? Should you call them to the hospital? No. You should not call them to the hospital. Rather, you should tell them how they should isolate themselves in home. What should they do? How should they monitor themselves? How can they monitor the oxygen? Even if they do not have an oximeter, then if they are having difficulty in breathing, they should immediately go to the hospital. If the fever is not settling, even after 7 days, then they must see a health professional. If they are having any problem, any severe weakness, for instance, and that is not being treated, they are having severe anorexia, which is not being treated, then they must see a facility. Otherwise, they should rest at home. And for fever, they can take paracetamol. They should not be taking NSAIDs, although the fever and the aches and pains may be quite high, but this is true even for non-pregnant women. And in pregnancy, we are more inclined to give paracetamol because that is found to be safe. So it is very important to take that. So in pregnant and postnatal women which are being cared for at home, in self-isolation, self-care interventions should be encouraged. They should know what is right and what is wrong, what are the things which they should take, whether vitamin D is required, whether iron is required, what kind of food they should take, and what are the danger signs which they should be able to recognize, whether it's the fetus or it's themselves, and when should they visit the health facility. Otherwise, if they are stable, then they should postpone the visit to the health facility to save the other patients around and to save the healthcare professionals. It is important that for 14 days they should isolate themselves and they should stay at home rather than going to the health facilities for a simple checkup, because there is no specific medicine which can be given in mild cases other than paracetamol. So then the antenatal counseling and care is important. Follow-up is important, and then this follow-up can be done at home, can be done on telemedicine, can be done on telephone, and the health visits should be rescheduled after the danger period is over. Advice, however, must be given that urgent care is required if they think that their condition is worsening, especially if they are developing acute respiratory symptoms. Now, another very important thing is that the patient is pregnant, and in pregnancy, there's a tendency to go towards anxiety, towards depression, and especially people who are inclined towards that. Now, if they develop COVID, if they are isolated, then they may develop severe mental health problems, which may even lead to suicidal attempts. So it is extremely important to detect this in the patients and give them psychosocial support or maybe even medicines if required. But this is really, really important. Then the anomaly scan, the growth scans, the antenatal appointments, they can all be delayed. Once the isolation is over, they can be rescheduled. So there are different timings which you should be doing an ultrasound scan in low-risk patients. In low risk, there should be one scan which should be done in the first trimester, and this is for the nuchal translucency, and this is for dating the patient. Then there should be another scan which should be done between 18 and 22 weeks of gestation, and this is the anomaly scan, which is done. In symptomatic cases, scan can be arranged after isolation period is over. So, I mean, they have a big window period, and easily the isolation period can pass, for instance, from 18 to 22 weeks. If they get sick at 18 weeks, they can do it at 22 weeks. So it's important. Then in the moderate risk patients, you have to do a little more frequent ultrasound scans, and in the high risk patients, however, you may have to do them even though the patient may be in isolation. For instance, if she starts to bleed, if the membranes have ruptured, if there's severe preeclampsia, if there's a severe fetal growth retardation, if there are no movements, etc., etc. So in those cases, since that is an emergency, you must do it, and you must not deny a patient of the medical help which is required. When should they be admitted? Should they be admitted? As I've already said, that if they are suspected or even confirmed cases, but with mild symptoms, even mild to moderate symptoms, they do not require admission. However, if they develop pneumonia, if there are signs or complications of pregnancy, danger signs which appear, then they should be admitted. If the oxygen saturation falls below 94 or 95, then they should be admitted. If there's a radiological confirmation of pneumonia, if they are immunocompromised one way or the other, if they are diabetic with CKD, etc., then they should be. For instance, there are a large number of people who may be immunocompromised, who may have had a renal transplant and now they're pregnant, who may have had an HIV, who may have primary immunodeficiency. All these are the patients who are at high risk of whether they have mild symptoms, they must be admitted and kept under strict surveillance. Now, all the hospitals, it's very important that people should know and the hospitals should know that whether they are going to cater for COVID-19 cases or not. And if they are going to cater for COVID-19 cases, then they must have isolated, designated areas for pregnant patients if they need admission, and for deliveries and for surgeries. It's extremely important that these areas should be separate from the areas where the general population is being delivered or having cesareans, or if they are admitted in the antenatal ward due to some other condition, then these areas should be different from them. So those who are supposed to come to the hospital, right, and if they are COVID positive, then it's important that they should use either their own private transport or they should come in an ambulance, not in a public transport, because many people are sitting besides them and they may also be infected. So one of the staff members should be alert, or once she arrives, she must immediately tell the staff who is at the triage that she has COVID. And because then she should be seen in a separate room with a person who's seeing this patient, should be wearing a PPE, should be covering the eyes as well as the mask should be there. And if the patients are not wearing masks, then they should be provided and they must wear a mask. There should be minimum attendance with them, and all non-essential items should be removed and all areas should be cleaned after the woman goes from that place. So antenatal, if the patient develops COVID-19, she may become serious. She may have a severe disease. You may need to do an early delivery just to save the patient, because she's not being properly resuscitated, not being properly ventilated because of a big baby present over there. So then it's important that you give as antenatal steroid cover if the woman is between 24 and 34, maybe even 36 weeks of pregnancy, because you may require an urgent delivery. And then pregnancy, you should understand, by itself is a hypercoagulable state. And in COVID-19, you have seen that DIC can develop and coagulation can develop in various vessels of the body. And it is important that prophylactic anticoagulation must be given to all these patients. Then the neonatal team obviously should be informed that there's a delivery of a woman who is COVID-19 positive, and they should take adequate care. So this is just to show you how things can go on if you come to the OPD or to the emergency or to the clinic. Then the symptoms should be assessed. There are no symptoms. There's the routine care. If the symptoms are there, then you have to see what kind of symptoms and their severity. There is no proper positive answer. You can assess clinically and go towards the risk factor, whether this is low risk or this is moderate risk. So if she has a positive answer towards the assessment, towards the severity, that means that she is a high-risk case. If she's moderate risk, then but there's no respiratory compromise, then follow her up with care and treat as low risk if she's getting better. If she's getting worse, then obviously she has to be treated as a high risk and may require admission there and then. Then there may be COVID-19 positive cases who are totally asymptomatic. So home isolation is required at least for 14 days. Nowadays, it's said that if you're symptom-free for 10 days, then isolation is finished, but it's always better that 14 days isolation should be done. Or if the home circumstances are not appropriate for proper isolation, then they should be isolated in dedicated government centers as appropriate. And educate the patient about getting what are the worst symptoms of COVID. So I'm leaving this because this has been discussed by the medical people, but an important investigation regarding this would be in pregnancy to do the liver function tests, to do the CPC, and if the platelet count is low, this may carry another risk for the delivery, and you may have to stop low-dose aspirin, you may have to stop the anticoagulation, and if you stop the anticoagulants, then it is important that you should give compression to the calf muscles so that the circulation is appropriate and there's less risk of developing DVT. So appropriate clinical assessment shows resolution of symptoms, and risk assessment of home environment indicates ability to isolate, and then this should be for 2 weeks. However, those cases who develop complication, the discharge may be much longer, may take a much longer time after 14 days as well. So when do you say that the person has recovered? It's when the person is totally asymptomatic 10 days after the onset of first symptoms. Then, or if she was positive, then 10 days she has remained asymptomatic, or she developed the symptoms, but now she is totally without the symptoms, or if 2 COVID-19 tests are found to be negative after a period of 24 hours. So now another patient. So we've discussed a patient who does not have COVID-19. We've discussed a patient who has COVID-19. And then what happens if you have passed your isolation period or you have recovered? So developing COVID-19 in the first trimester and the second trimester, whether COVID-19 gives rise to any fetal anomalies or so is not really clear at the moment, but probably not, hopefully not. And then in the second trimester, if the person just crosses this time period, even if the disease becomes severe, the baby may be absolutely normal. So, but you have to follow this patient up. And in the third trimester, especially if she develops severe symptoms, she may need to be delivered at that time. So if with the mild, moderate, or no symptoms, obviously the antenatal care should continue and the missed visits have to be arranged. However, a patient who has recovered from serious illness may require much more vigorous antenatal care to look for a growth retardation of the baby, to look for any signs of hypoxia in the mother, which may affect the baby as well, and to look for tachycardia in the mother, which is a very common symptom for many weeks after recovery from serious illness of COVID-19. So then I purposely missed the part of delivery and missed the complications, because Dr. Shahnaz is going to discuss those. So I'm just coming to the postpartum care, what is important in the postpartum care. Women and healthy infants, they should be kept together. This thing should be very, very clear. You don't need to put a mask on the face of the baby. The baby may choke with that mask. But the mother needs to put a mask on the face. She needs to wash her hands before she carries the baby. She needs to wash her breast, and she can even breastfeed. I'm not even going to touch the newborn aspect because I think General Salman is going to do that in the pediatric section and the neonatal section. But what is important is that a kangaroo mother care, a skin-to-skin care, breastfeeding, and keeping the baby with the mother until and unless the mother is really, really seriously ill, then obviously it cannot be. But otherwise, the baby should be with the mother, and the mother has to take a little bit of precautions to prevent the baby from getting the disease. Now, contraception. This is really important. I already talked about it, but during pandemic, the last priority becomes the contraception. And this results in so many unwanted pregnancies, which have to be managed, and it becomes a big problem. So all modern contraceptives can be safely used. IUCD, copper T, multi-load, levonorgestrel Mirena system, they all can be inserted immediately after delivery. And after an evacuation or a DNC. After an evacuation, IUCD can be inserted after completion of abortion or on a follow-up visit. This can also be inserted after delivery, 6 weeks after delivery, or it can be inserted there and then at the time of delivery or a cesarean section if that is carried out. So these are the various references, and I'm really thankful to WHO and SOGP. Most of the slides are shared from a workshop which we are going to do. And these are guidelines provided by the WHO and by SOGP, a combined document has been formulated in the Ministry of National Health Services Regulation and Coordination of Pakistan, and it's first of its kind, and really a big document which has been prepared by the ministry with the help of these people. So, having talked about antenatal care, the problem with pregnancy, I mean, I wouldn't say a problem, but the thing is this, that pregnancy may land into emergency at any time. The expected date may be 9 months ahead, but you may suffer from a miscarriage. You may suffer from bleeding. You may suffer from ruptured membranes. You may suffer from high blood pressure. You may have severe hyperemesis, that's vomiting, nausea, etc., which results in electrolyte imbalance, which may even result in hepatic failure if it's not treated properly. So you can have any low-risk pregnancy can be converted into a high-risk pregnancy, and you have to be on your guard, and you have to consider this as an emergency situation. And if a patient comes in labor, or if a patient needs an urgent cesarean section, whether you know she's COVID positive or you don't know that she's COVID positive or negative, or you suspect that she's COVID, you still have to deliver her. You still have to do a cesarean section if that's required. So then it's important for the team to know what are the precautions. It's important for the administration to know that which is the designated area for that, because you cannot delay that. So that is important. So where we work, that is in obstetric and gynecology. Obstetric is absolutely different from gynecology. So gynecology is you do elective procedures such as removal of a polyp, a fibroid, a uterus, ovaries, cysts. You can do laparoscopic surgeries, you can do hysteroscopic surgeries, or you do emergency gynecology such as an ectopic pregnancy, such as torsion of an ovarian cyst, in which the patient comes in severe pain, and if you do not do anything, you may lose the ovary as well. So those are emergency situations in gynecology, but most of the problems of gynecology are elective problems, and how should they be dealt with in a COVID pandemic? That is also very, very important. I'm going to be very brief with this. But the objective is there, it was the vertical transmission, whether it occurs or it doesn't occur, but also there was horizontal transmission. Now, in this, what is important is to reduce the risk of person to person, that is horizontal transmission of COVID-19, to optimize patient outcomes, and to make the best use of limited human and physical resources. So, risks. What are the risks? There are lots and lots of risks of conducting elective surgeries, especially under GA. At the time of intubation and at the time of extubation, aerosol generation which occurs, that can be very, very dangerous for anybody who is in the theater. Then there can be viral particles spread as air droplets from within the surgical smoke. Regional anesthesia should be preferred if it's must to do procedure. GA should not be given as much as possible, obviously. Then another important thing is that laparoscopy and hysteroscopic procedures should be postponed if they can be, because even if you have to do a procedure, for instance, for a ruptured ectopic or an ectopic pregnancy, if you prefer laparoscopic surgeries, but in this COVID pandemic, especially if you've not done a test of that patient and you're not really sure, then it is better to do an open surgery rather than do a laparoscopic surgery, because the aerosol which is generated can be quite dangerous for the healthcare professionals. And then the body fluids, it has been found in the peritoneal fluid and also in the blood. So you have to be careful with that during surgery. And another very important thing is that if a patient is symptomatic, obviously you will try and avoid the surgery, elective surgery, if it's necessary. But what about the asymptomatic patients? It has been seen that the clinical outcomes are the worst in asymptomatic patients uh, who undergo surgery. Why? Because this surgery is a further stress on them. They already had COVID-19, but they were asymptomatic or they had not developed symptoms up till now. Now this can worsen and this can accelerate and this can even result in mortality of the patient. So it is important not to do elective surgeries of these patients if they are not required to be done during these times. And these risks may be proportional to age, surgical complexity, and patient comorbidities, but this is a very, very important risk. So if the patient is COVID positive, what should you do? If you can postpone, then you should postpone the surgery for at least 14 days from the onset of symptoms. And once the patient is clear that the patient is COVID negative and will not infect the others around her. The person is COVID negative, but still the person is a suspect because it's running fever. It obviously can have many other causes as well, but you should still suspect and you should postpone the surgery. Advice should be given regarding self isolation, and again, you should reassess after 14 days, and then the surgery should be planned. But what about the emergency procedures? I think it's important. You need to understand that emergency procedures cannot be delayed. And testing, it's important that testing should be done prior to emergency, but sometimes it's not possible to get the results of that. But if it is absolutely essential, you should not delay the procedure just because you want the result, because then the patient's life is at stake. So it's important that if you can delay, then you should wait for the test results. But if the condition of the patient is such that delaying the procedure will increase the mortality or morbidity of the patient, then do not delay, but take all the precautions which are required for this. So in the theater environment, however, there are many people you can see in this photograph, but there should be minimal people present in the theater, and they should be all covered from head to toe. They should be covered with any PPE or any gown which does not allow fluids to pass through it. Their face should be completely covered, but if it's complete coverage, then a respirator may be required. So you need to take proper precautions before you can, especially at the time of intubation and extubation of the patient. So these are the various personal protective equipment which is required and which should be used during surgeries especially. However, as I said, that if it's not necessary, for instance, in heavy menstrual bleeding, you may have opted for hysterectomy of a patient, but now non-surgical methods should be considered till the time the pandemic is over or till the time the patient, if positive, has turned out to be negative. So all non-surgical modes must be utilized. They may help the patient. Sometimes they don't help the patient. You may have to reconsider, but still, if it's not a dire emergency, you should avoid doing gynecological surgeries during the pandemic. Now, thank you very much. Stay safe and stay positive always. And it's time that if you want to ask any questions,
Ma'am, we will be commencing our question and answer session if that's okay with you.
yeah,
First, thank you so much for this insightful session. I thoroughly enjoyed it, and we have lots of questions, so we'll get to them now.
no problem.
Okay, so the first question is COVID medication different in pregnancy, and do any of the drugs used normally in COVID patients have any teratogenic effects?
The thing is this that I mean, there is no specific treatment for COVID, if you ask me, right? You can use paracetamol, that is safe in pregnancy. You may have to use remdesivir, which is an antiviral drug. Its safety is not confirmed in pregnancy, but if the patient is having serious COVID, then you have to give this medicine. Anticoagulation is used. You should use the safe anticoagulants, which are safe in pregnancy and they are given in pregnancy. And there is no other medication which is really used. It's just the oxygen which needs to be given to any person who's developed serious illness, which is the respiratory disease. But obviously, if multi-organ failure is occurring and if any treatment is required, you cannot deny the woman of that treatment, whether it is teratogenic or it's not teratogenic. Mother is more important than the child. But in mild to moderate disease, there is no set treatment, so you don't need to give anything.
Right, ma'am. So the next question is from Dr. Aisha Mehnaz, and she's asking, what are the guidelines for breastfeeding if the mother is COVID positive or has recovered recently? And are there any general precautions that should be taken while breastfeeding during the pandemic?
Okay, I actually originally wanted to talk about breastfeeding as well, but since that's a topic which is going to be separately covered completely by General Salman, I think I would advise her to listen to that talk as well. That's going to be really nice. So I cut those slides off. But the thing is this, the thing which I would just like to say it over here is that, yes, the woman should breastfeed unless and until she's seriously morbidly ill, right? In mild to moderate cases, she can breastfeed. She should be wearing a mask and she should wash her hands every time she picks up her baby. There is no other precaution which can be taken. This is recommended by WHO and it is being practiced everywhere in the world with no side effects to the baby.
All right, ma'am, thank you. The next question is, do we know of any known side effects of COVID on neonates born to COVID positive mothers?
Not really. Not really, right? There are a few cases in which stillbirths had occurred or in which preterm deliveries had occurred. And again, I would like to say this, that I deliberately missed this portion. Okay, what are the side effects which can occur during pregnancy or in the neonate? Because this is going to be covered by Dr. Shahnaz, the complications which occur, right? But the thing is this, that up till now, teratogenicity has not been proved as a result of COVID, even if she acquires it, because teratogenicity usually occurs if the disease occurs in the first trimester, right? But it has not been proved up till now that there is any teratogenic effect on the neonate. And moreover, preterm labor can occur. There can be some complication like stillbirth, etc. If the mother is running high fever, or if she's really short of breath and has low oxygen, then she can have that. But otherwise, there are no other proven side effects. But as I say, this is off today, and every day the guidelines are changing, and every day new things are coming up with experience, obviously, since there's a new disease. Although many people of the world have been infected with it, but those cases which are being reported, obviously, they are being analyzed, and what is seen is this.
Right, ma'am. Thank you. So the next question is, till when can you delay the anomaly scan in a COVID positive patient?
When can you? Okay. The thing is that anomaly, why do we do an anomaly scan? Right? I mean, that's important. We usually do an anomaly scan that if at 18 weeks or at up till 22 weeks, if the patient has an abnormality which is not compatible with life, then usually we terminate pregnancy. Or if there's a minor abnormality, then we are on our alert and we have to discuss with the pediatric surgeon, with the neuro surgeon, etc., and we carry this pregnancy forward, right? So it is not a hard and fast rule that every woman must have an anomaly scan. It is much better to have it at that time, but even there are people who get it done late, but the only thing would be when they get it done late, for instance in the third trimester after 28 weeks, even if they are found to have abnormalities which are incompatible with life, we usually do not deliver them at that time because now the fetus is viable. So that is the problem which they can face, right? So but the best time period for anomaly scan would be 18 to 22 weeks. So if she develops COVID at 18 weeks or at 19 weeks, it can be delayed for 2 or 3 weeks and then get it done after that.
All right. Thanks, ma'am. The next question is, since pregnancy already is an immunocompromised state, did you in your practice observe a higher number of infections in pregnant women as compared to the general population?
Not higher number, but obviously here and there, we came across a patient who was COVID positive, but it was like in a general population.
All right, ma'am. Thank you for that. The next question is, and Dr. Iqbal Haider is asking this, should oral steroids be prescribed to pregnant COVID-19 patients?
If required, yes, they can be prescribed. But it depends. If they're given in the first trimester, then there may be certain teratogenic effects on the fetus. So you have to be careful, but if they are really needed in the mother, they can be given.
All right. Right. So the next question is, are novel anticoagulants like rivaroxaban safe during pregnancy in COVID-19 patients?
As I had already mentioned, that their safety is not proven. If it is necessary to give, their treatment is also not proven, if you ask me, right? So if you can avoid, you should avoid. But if it's absolutely essential, if the physician thinks it's absolutely essential, then again, I would repeat that mother is more important, obviously. So you have to give whatever is required. But the problem with these injections is that their efficacy in COVID is not yet proved, right? So giving a thing which is not proven and which may have side effects, you have to weigh the pros and cons.
All right, ma'am. Thank you. The next question is, has COVID-19 impacted the care-seeking behavior of pregnant women? Are they seeking the routine care or hesitating to come to clinics?
I mean, it has really reduced the antenatal care. And people were really scared, especially I'm talking of Pakistan, right? When there was a lockdown and all the other people, they were just coming for nothing, but pregnant ladies were a bit more scared as compared to this. But that also had a bad effect because, in our country, telemedicine, availability of doctors to advise, proper doctors to advise the patients, etc., and one-to-one contact is very poor, I would say this. So what happened was that now, as we are seeing patients, we are seeing many complications because they did not have an antenatal checkup, so they were not diagnosed early. For instance, day before yesterday, I saw a patient who had a morbid type of large spina bifida and a marked hydrocephalus, and she was at 30 weeks. And she said she got her ultrasound, her anomaly scan done at that time because she did not go out of her home. I mean, it was good that she didn't, but now she was really, really concerned and she wanted a termination. I said, I mean, at this stage, you cannot do a termination, right? So the thing is this, there were people who developed growth retardation. There were people who developed severe preeclampsia. They went into eclampsia as well, but they did not seek medical help because of the scare of COVID.
Right, that seems like one of the things
that will definitely change the behavior, especially of pregnant ladies.
Right. Ma'am, the next question is, what would be your recommendation to strengthen and improve services for pregnant women under these challenging circumstances?
With services? With services? Sorry?
I believe that they're talking about like pregnancy services, like prenatal services, I'm guessing.
Yeah, the thing is this, that prenatals, our health systems are already choked, if you ask me, right? The government health systems. The private health systems are, some may be excellent and others may be really pathetic. That's the main problem with systems like in our country. So, what is important is that in these circumstances, the best thing would have been that you can see the patient on a telemedicine, on a video conferencing, on a WhatsApp, but seeing a patient, right? And discussing her symptoms, etc. But I don't know, you really need dedicated people for this purpose, and you really need to establish such centers where the patients, and the patients also need to have that IT technology. So otherwise, home visits would be more appropriate as compared to women coming to the hospital where there are many people sitting around, and when there, and there's a more likelihood of catching the infection. So home visits would be. But even for home visits, there are lady health workers in our country, and there are some community midwives, etc. But the thing is this, that home visits are also not very well scheduled.
Right. Especially in Pakistan, I suppose that is the.
I'm not talking about Pakistan.
Definitely. So the next question is, can you comment on the role of family physicians in preventing maternal mortality? I think it's linked to what we're already talking about.
I think that's that they should be the key people. In any country, they should be the key people, the family physicians, because first, any family, and they have a very good liaison with the whole family, and they know what is going on in the family, etc., etc. And they should have a basic knowledge as to what are the complicated factors, at which time they should be properly referred to a proper specialist or to a hospital, etc. So they also need training, and especially COVID-19 by itself, and for other signs and symptoms which may lead to problems in pregnancy, for appropriate referral. But they should be the pillars of the society.
Yeah, absolutely. Ma'am, the next question is, what is a recommendation for tetanus vaccination in COVID-19 positive pregnant women in her last trimester?
The thing is this, that actually tetanus should have been given. I mean, everybody should be vaccinated with tetanus. There are total 5 doses which should be given. But since we know that, and we don't even question, because they don't even know whether they have been vaccinated with tetanus or not, right? They have never received booster doses. So what the routine over here is, and what is the recommendation of the WHO is, that you usually give 2 doses, sometimes 3 doses of tetanus in during pregnancy. It can be given any time after the 3rd month, but it's usually given in the 6th or 7th month. So the first 2 doses are 1 month apart. Then if you want to complete this, then the 3rd dose would be 6 months later, right? So if you give it at the early 4 months, then you can give it at 5 months, and then you can give it in the last month of pregnancy. So, but usually 2 doses of tetanus must be given during pregnancy, because you don't know what the status of their tetanus immunization is.
So tetanus is safe during, even in a COVID positive patient.
Must be given.
Right. And the next question is, do you have any advice regarding family planning for new couples?
I mean, it depends upon what they want, really. Yes, there are many advices, and I think it's very important that even a new couple should do family planning for quite some time. But obviously, this depends upon the individuals. What do they want? What kind of family planning do they want? For how long do they want? So it all depends upon that. But the safest things should be used. And if you must know what is the failure rate of any contraceptive, and you must know what is the safety of that contraceptive, and you must know for how long you want a contraceptive, and then you can select between any one of them. And even for newly married couples, why not? They should be able to understand each other before they have a child.
Ma'am, since OCPs are known to be a risk factor for increased clotting, in a COVID positive patient, is it safe to be using OCPs?
I mean, it's better not to use it if you're COVID positive now, right? So, I mean, obviously for some time after being COVID positive also, you still have the risk, and it is recommended that anticoagulation therapy must be given between 2 and 4 weeks after being COVID positive. So you should not be using any such thing which may further enhance this.
So what would be your advice for a patient who's using OCPs? What should she shift to from OCPs?
She can shift to physical, for instance, the condoms, etc. But the thing is this, that if she is COVID positive, then probably there would be less of sexual activity as well. And the best thing would be to shift on some barrier methods.
Right. Thank you, ma'am. Another question by Dr. Fahad is, we have a very weak critical care setup for maternal and neonatal support. How big of a challenge was it during this crisis?
I mean, I would say Allah has really helped Pakistan, because if it had been like it was, we would have choked. The whole system would have choked and come to really a standstill. But we were lucky enough that there was a time when the system was choked, but that time passed earlier than what we expected. And our systems are already full of patients. Our ICUs, which are already there, I mean, I'm talking of a government setup. And in the private setup, there are very few private setups who have the facilities which the government hospitals have. But at the same time, the load on the government hospitals is so much that they, even for normal, I would say normal diseases, to cater for an ICU in obstetric patients was always a problem. When I was working in Holy Family, I mean, we were always looking for a bed in ICU for a serious patient who came in obstetrics, and it was no pandemic, right? So what happened to all those people who actually required ICU? So a lot of people had, I think, denial of other facilities as well during this COVID, because everything was converted into COVID positives. But even that was really, it was very difficult for all the hospitals to cater for that. But thanks to Allah that the number has reduced, and now it's manageable at least.
Yeah, absolutely. Thank God for that, ma'am. So the next question is, what are the precautions that you believe should be taken by doctors who are operating on COVID positive mothers or in a gynecological setting on a COVID positive patient?
All right, I had already shown you the precautions, but the thing is this, that if while in OPT, it's important that you should be wearing masks. And it's better that if you can wear your surgical scrubs, and you can wear a gown on top of that, right? PPE is not required for a general OPT, but PPE is required wherever there is, I would say, a definite COVID patient. So those should be designated separate areas, and in this you should have a proper PPE, you should have a proper cover of your eyes, a proper mask, which should be an N95 mask minimum, and the head cover. So you should be wearing double gloves, and you should be taking care not to touch any fluids, not to be in direct contact with the aerosols, etc., which are generated. But otherwise, the care is the same. But you need to clean all the surfaces, the bed, the linen, etc., etc., when the patient is transferred from that place to another place, right? And so these are the precautions which the doctors have to take. And the doctors really, I would like to, I was also one of the victims of COVID, and I actually became very, very serious. But thanks to Allah that I came back, and now I'm working back in the same environment. And but the thing is this, that you have to be careful, but doctors are at very high risk of contracting COVID.
Yeah, absolutely, absolutely, ma'am. So the next question is by Dr. Amna Khan, and she's asking that she has observed a lot of intrauterine deaths in this Corona COVID period. What could be the possible cause?
The thing is this, that up till now, although intrauterine deaths or stillbirths may have increased, but they are not directly related to COVID. Although high grade fever, although hypertension can occur as a result of COVID in a non pregnant patient as well. If a pregnant patient already has hypertension and she develops COVID in a severe form, she may lead to severe preeclampsia, eclampsia, and intrauterine death can occur. I think as a Pakistani, it is very important that if we saw any patient who was COVID positive, we must report this patient properly, and we must report the condition of the baby as well, because as I said, since this is a new disease, it will take time to discover each and everything regarding this disease and regarding its effects on the neonates.
Thank you, ma'am. This question is regarding an extremely important topic. I believe it's about domestic abuse. Do you believe that the incidence has increased during this time? And what do you believe? Do you think that has COVID had an extra psychological impact on people who are already going through domestic abuse?
I think, Maham, this is again a very, very important question. Domestic abuse has definitely increased because people were sick of seeing each other, sick of not having to do anything, and sick of sitting at home and seeing the same faces again and again. And they were also psychologically stressed, upset. A lot of anxiety was there, and the abuse has definitely increased. And this has to be, for countries like us, it's mostly, even in other countries, usually the women are the victim because they have no place to go, and they are this thing has definitely increased. In China, it was seen that in a particular area the divorce rate had increased markedly after that, after the lockdown. So the lockdown did have a very bad effect. It also had many good effects as well. You were away from your family, you were just working and working and working and working, and this was probably the first time you saw your family, or rather you met your family. So I think it had its good effects as well as its bad effects, and amongst the bad effect, this abuse has definitely increased.
Ma'am, what would, furthering on to the same topic, what would be your suggestion for physicians, especially who come across such patients, or for the patients going through this, any sort of support or helplines that they can use during this time?
Yeah. I think, Maham, your ventilators for Pakistan is doing a very great job, and I think this should be it. This should be our way forward. But it should not be because the thing is this, that I actually believe that in our country, people who can have an access to these things are usually a little educated people or resourceful people, right? But people who actually need help do not have these facilities as well. So you really have to think, uh, what should we do to improve the maternal health in the low trodden areas where these gadgets, etc., are not available. So there should be helplines. There should be helplines from the government. There should be ambulance services, which everybody should know. Like everybody knows 1122, what is that for? Like everybody knows ED. There should be ambulance services for maternity, especially. And I think that should be a way forward, because you cannot go to every home, but you can at least have dedicated people to bring the woman over if there is an emergency of any kind.
Absolutely, ma'am. And I think that we do have services or taxi services or courier services that could be used in that manner as well, like they are in the US now. But inshallah, let's work on that as well under the banner of VFP one day. So the next question is by Dr. Iman, and she's asking that if a mother has had COVID-19 and has recovered, would she be able to transmit antibodies to the baby either through placenta or breastfeeding, like vertical transmission of antibodies?
I'm sorry, Maham, your voice was not clear. You'll have to repeat the question.
Okay. Is it fine now?
Yeah.
All right. So Dr. Iman is asking if if a mother has had COVID-19 and has recovered, would she be able to transmit antibodies to the baby either through the placenta or through breastfeeding?
Yes. The thing is this, that there are two kinds of antibodies, as I showed you in my earlier slides. There's an IgM antibody and there's an IgG antibody. The IgM antibodies do not cross the placental barrier. So IgM antibodies, if present in the blood of the neonate, would mean that the baby had an infection himself, and then he responded to that by making his own IgM antibodies. But IgG antibodies can freely cross the placenta, and they can go to the fetus, and they are present in the neonate, and they can even give immunity to the neonate. That is how immunity to a number of diseases is given for the first 4 or 5 months, because a lot of IgG antibodies, they are transferred from the mother to the fetus. And breast milk also is a very good source of giving immunity to the baby in this manner. So IgG antibodies, yes, and it is the IgG antibodies which protect you.
Ma'am, so we've circled back to GPs, and Dr. Asif is asking if you could give your valuable comments regarding the research culture at GP level. Do you think that they should also become more involved in evidence-based medicine?
I mean, there is no saying that. I think everybody should go for evidence-based medicine. And I think we should have our own guidelines. For each and every disease, we should have our guidelines, and everybody should follow those guidelines. Till the time we do not have guidelines, there are guidelines present in the world of different colleges, different royal colleges, etc. We can follow those guidelines, or we can follow the books. But I think everything should be evidence-based rather than just giving whatever you feel like giving and doing whatever you feel like doing with the patient, whether it's a GP or it's a specialist.
I think one of the issues that we face in Pakistan is that everybody wants to experiment and have trials on their own. So yeah, we can always address that. So the next question is, pregnancy has a known side effect of increasing clots, and COVID-19 has a similar effect, as we learned through the pandemic. Does pregnancy and COVID-19 further increase the chances? And what prophylaxis do you suggest for these patients?
Sorry, chances of
increased clotting.
Yeah, it does, definitely. You know, pregnancy by itself is a hypercoagulable state. There is a high risk of developing DVT, and there is a proper chart which tells you that which are the high risk women, and you should give them prophylactic anticoagulation, because they may develop DVT, or they may die of pulmonary embolism. Now, COVID by itself has a very important complication, and that is coagulation, which can be in the lung vessels, which can be anywhere in the body, or it can be everywhere in the body, right? And all those patients who have a high D dimer test you must do a D-dimer test as well. So all those patients who have a high D-dimer test, they are at higher risk of developing coagulation due to COVID, and they must be put on anticoagulation. And whether they were with an increased risk before or not, now they are definitely at an increased risk of coagulation. So you must give them anticoagulation.
So basically, it all depends on the level of D-dimers in that patient.
Yeah, but in pregnancy, you should give anticoagulation. If the patient becomes COVID positive with symptoms, you must give anticoagulation.
Right. All right. Ma'am, unfortunately, this was the last question, and this wraps up our question answer session. I think that I had an amazing time just learning everything that you had to say, and I would definitely want to further this session, perhaps in another session that we could organize with you.
Thank you very much, Maham. It was really a pleasure. I was just looking, that's been almost 1.5 hours. Amazing. So it was, thank you very much. And I would really like to comment on your patrons, General Akhtar, who is gem of a person, and Professor Samia, and Saba being daughter of Jan Lakhtar. And Jan Lakhtar's wife was my teacher, and I'll never ever forget her. She was Professor Khalda Deep Khanum Akhtar, and she always lives in the hearts of the students. And she was one gem of a teacher, honestly. And they are doing a fantastic job, and this is her legacy is being taken forward. Thank you very much. I am honored to be part of it. Thank you.
Thank you so much, ma'am. It was an honor to have you. A personal honor as well for me. Thank you so much.
Thank you.
Ibrahim, over to you now. Thank you so much.
Thank you, Dr. Maham, and thank you, Dr. Rizwana, for such an excellent lecture. We all learned a lot from it. I would now like to introduce our second speaker for tonight, Dr. Shahnaz Nawaz. Dr. Shahnaz Nawaz graduated from Khyber Medical College, Peshawar. She did her postgraduate training from the UK, and after attaining MRCOG, she worked for 6 years as a consultant obstetrician and gynecologist in Saudi Arabia and for 10 years in the UK. Currently, she is appointed as the Associate Head of Department and Consultant in OBGYN at Shifa International Hospital, Islamabad. Dr. Shahnaz Nawaz is BSCCP, which is the British Society for Colposcopy and Cervical Pathology accredited colposcopist, and has expertise in urogynecology and laparoscopic surgery. She has been an examiner for the MRCOG exams in the UK and faculty member for the MRCOG Part 1 and 2 courses in the Royal College of Obstetricians and Gynecologists. Furthermore, she was appointed by the Royal College of International Convener as an international convener for MRCOG Part 1 courses in both Indonesia and Lebanon. In Pakistan, she has served as the Member of Council in the PMDC and is a member of the Board of Governors for the Lady Reading Hospital in Peshawar. Dr. Shahnaz, thank you so much for joining us today. With your permission, I would like to request you to now commence the session. Over to you, ma'am.
Thank you, Ibrahim. It's a pleasure to be able to work on. I would actually second what Dr. Rizwana Chaudri has just said about ventilators for Pakistan. You're doing a tremendous job. And
thank you.
Okay. So yeah, I have had a bit of a problem to upload this presentation on my laptop. So I'll keep asking to forward my slides. If I can start it.
Of course, that wouldn't be a problem.
Okay. So I'm going to discuss complications and risk of pregnancy due to COVID-19. Next slide. So the maternal risk of COVID-19 in pregnancy are plentiful. The good thing here is that the pregnant women do not appear to be more likely to get the infection compared to the general population or their counterparts. And the other good news is that these women are likely to experience mild or moderate flu-like symptoms rather than a severe illness. Next. So in May 2020, the CDC, the Center for Disease Control and Prevention, this is an American organization, they stated that the pregnant women have the same risk of severe illness from COVID-19 when you compare them from non-pregnant women. But in July 2020, they changed this statement and they said that in fact, the risk of acquiring severe illness is more likely, the risk of acquiring severe illness is more likely in pregnant women than non-pregnant. And they stated that the virus had a 50% higher chance of being admitted in pregnant women to be admitted in intensive care and 70% higher chance of being intubated than non-pregnant women. And this was actually, there was an article published in Medscape only yesterday. And this American statement is based on, as we all know, that about 600,000 women, people died of COVID-19, and about over 1.5 million were affected from this virus, and 25% of them were in America. So what they looked at a cohort of 300,000 pregnant women who were positive for COVID-19, and they looked at the statistics, and that's what they have come up with. UCOS is another organization in the United Kingdom, which is actually United Kingdom obstetric surveillance system. It's a very, very effective system. It looks at rare diseases in pregnancy, and they've been assigned to look at COVID in pregnancy because it was something new and rare. So what they did, they looked at their data and they found that about 1 in 10 women became pregnant women so ill that they required respiratory support. Next, please. So what about the maternal mortality with COVID-19 in pregnancy? So when we look at the UCOS figures, which actually looked at 427 women, they found that 5 of them died of, and pregnant women, they found 5 of them died of the illness. The time period of study was from March 2020, 1st of March 2020 to 14th of April 2020. So when you compare maternal mortality figures, in UK, it is about 9.2 per 100,000 maternities. And when you look at the percentage, it's 0.0092%, whereas in COVID mortality is 1.17%. So it's extremely high. So this old concept is actually dying, that pregnant women are at a low risk. Okay, they're probably at the same risk of acquiring the illness, but when they get it, especially in later pregnancy, there's a high risk of them dying of the condition. Next, please. So when we look at the maternal risks, we have to look at the operative risk. So they found that the cesarean section rate in COVID positive mothers in the UCOS study was 59%. It's coming up to nearly 60%. And UK would have relatively lower compared to the North American cesarean section rates. So at worst, it is 50%. At best, it is about 20%. So this is quite a high figure that we are looking at in COVID days. And it was found that this general anesthesia was given more frequently. So if you look at, for cesarean sections, if you look at cesarean section rate of conversion to general anesthetic from spinal or epidural, it's about 5% or less. In this case, it was 20%. And it was thought that it is because some women had such bad chest problems and other such severe illness that they had to recourse to general anesthetic. Next slide, please. So this is a very interesting slide, and this figure actually astonished quite a few of us, because in Britain we were seeing that even in the healthcare professionals, it was the browns and the blacks were dying. It was the Asians particularly, and some of the Asian doctors that I know have died in UK. So this UCOS actually found out that the Black, Asian, and minority ethnic minority people had a high risk of admission from COVID-19 during pregnancy. This was also the case in women who were obese, had pre-existing comorbidities, and they were older women, more than 35 years of age. The median gestational age at hospital admission was 34 completed weeks. And that's why the Royal College actually recommended that heavily pregnant women should avoid, doctors and other healthcare professions should not be in the front line when dealing with COVID-19 patients. Next, please. So Dr. Rizwana Chaudri has discussed the risk of venous thromboembolism and has rightly mentioned that pregnancy is a hypercoagulable state, and with COVID-19, with its own inherent increased hypercoagulability, it is associated with increased risk of maternal venous thromboembolism. Next, please. So how do you prevent it? So women who are self-isolating at home, and they are either symptomless or they have mild symptoms, they should well hydrate and should be mobilized. They should not confine themselves to bed and should actually be active so that they reduce their risk of developing thromboembolism. However, women who are admitted with confirmed or suspected COVID-19 should receive prophylactic low molecular weight heparin unless birth is expected within 12 hours, because then these women might need spinal or epidural, and then it would be risky to give these local analgesics because of risk of causing hematoma. Hospitalized COVID-19 positive pregnant women should receive low molecular weight heparin for 10 days following the hospital discharge. This is a recommendation by the Royal College of Obstetrician and Gynaecologists. However, women with persistent morbidity like hypertension, diabetes, obesity, or they belong to the BAME group, then this longer duration of thromboprophylaxis should be considered. And women admitted with confirmed or suspected COVID-19 within 6 weeks postpartum should also receive low molecular weight heparin for at least 10 days post-discharge, and consider extending this duration to up to 6 weeks in ongoing morbidity. Next, please. So, we briefly mentioned the mental health problems. Yes, there is definitely has been an increased incidence of mental health issues, and some of my patients have actually admitted that they were going through a period of extreme anxiety. The anxiety was revolving around the fact the COVID-19 itself. They were worried in case they get it. They were worried because a new disease, we did not know, they did not know how will it affect them, how will it affect their babies, and then the effect of social isolation, resulting in reduced support from the wider family and friends. And then a lot of people were laid off from their jobs. The businesses were badly affected. So there were financial issues as well. And we all know that financial issues have effect on one's mental health. Then there were changes in antenatal care. Appointments were based on telemedicine or telephone instead of face-to-face, or some women decided or did not have the resources or the technology to get in touch through these gadgets, and they had no contact with their healthcare providers, and that resulted in isolation, in anxiety, and stress. Next, please. Next. Yeah. So again, domestic abuse was one of the questions, and Dr. Rizwana Chaudri has rightly highlighted this issue that if an abusing partner is there, so if he's there all the time compared to the fact that he's there sometime, so obviously the abuse was also doubled. And with the fact that there were these added anxieties with job loss, with the financial strains, with the social isolation and where to go, and being stuck at home, so that resulted in increased level of domestic abuse. So these women should be encouraged, if healthcare professionals come to know about it, and should make every opportunity to inquire about it. If you suspect it, then support should be offered. Now, unfortunately, Pakistan does not have a very good support system here. But if there is domestic abuse is so severe, then I think the police should be involved. Next, please. So we move on to the fetal complications of pregnancy. Again, the good news is, and it's already been highlighted, that we don't have data to suggest that there is increased risk of miscarriage in relation to COVID-19 when it is acquired in early pregnancy. And furthermore, there was no increased risk of congenital abnormalities in these babies who survived. Next, please. So we talked about preterm birth briefly. So it was found that there was the risk of preterm birth was 27%. But when we compare it to the non-COVID population, it was 7 to 8%. So there was a 10 times rise. So when these figures were looked at, it was found that 47% of these were iatrogenic for maternal compromise. So if the woman was getting so much compromise that affected causing pneumonia and needed ventilatory support, etc., so then it was imperative to deliver these babies to reduce the compromise on the maternal lungs. But unfortunately, there were significant proportion were actually spontaneous preterm births as well in COVID positive patients. Fetal growth restriction was also observed, and which I have personally observed. Quite a few of my patients had fetal growth restriction. When we look at the pregnancy in non-pregnant population, the risk of FGR was 10%, and it was 2/3 of COVID-19 pregnancies were affected in fetal growth restriction. So this was quite high. Therefore, if a woman is affected by COVID-19, then it is mandatory that ultrasound scan follow-up should be carried out, so that this condition is not missed out, and appropriate care is given, and for possibly prophylactic steroids. Next slide, please. Next slide, please. So now, when we look at the UCOS figures for 2020, the perinatal death was 5 in 427 patients that were studied from 1st of March to 14th of April, which amounts to 11.7 in 1,000. When we compare it to the perinatal death of 2016, the perinatal death rate is 5.13. So again, these figures are doubled in pregnancies affected by COVID-19. Amongst the 5 babies that died, 3 were stillbirth and 2 were neonatal deaths. Next, please.
Dr. Shahnaz, could you, I'm sorry to interrupt, but could you please speak a little louder? Some of the participants are having difficulty hearing you.
Okay. So what is the risk of vertical transmission? So I'm not going to elaborate more on this slide because Dr. Rizwana Chaudri has described that. Can we move on to the next one, please? Sorry, I've lost the slides. Yeah. So the risk of vertical transmission. So I put a question mark because we still do not know whether vertical transmission does take place or not. So the 2% of the infants had evidence of viral RNA in sample taken within 12 hours of birth. Whether this transmission took place in utero or whether it was during after birth, we are not sure. The conclusion is that there is not enough evidence to suggest that these were congenitally acquired infections and should be classified as possibly neonatally acquired infections. Next, please. So I'm now going to talk about delivery in a COVID positive mother. Next slide, please. So if a pregnant woman who is known to have COVID-19 or is suspected to have COVID-19, she should notify her obstetric unit before arrival so that the facility can be maybe put in place for her reception and for her delivery. So this is the guidance we've received from CDC. Next. So whenever the patient walks in to the hospital and before and even entering the labor and delivery ward, these women should be screened for signs and symptoms of the COVID-19. So the temperature should be checked and she should be asked if the patient has had any direct or close contact with the confirmed case and also looked at the symptoms of fever, new cough, shortness of breath, sore throat, muscle aches, rhinorrhea, nail congestion, and loss of smell and taste. Next, please. So again, this is, I'll just touch on it because it has been elaborated earlier, that healthcare workers should use appropriate PPE when caring for patients known to or have suspected COVID-19. All the patients and the visitors should be given face masks upon entry into the healthcare setting. Now, there are major concerns during active labor of viral dissemination. When the patient is forcefully exhaling especially during the second stage of the labor. And it is very difficult to make sure that the woman has her mask on because, you know, when anybody who has attended labor ward, that woman is not receptive to your instructions and when she's stressed, she can even throw up the mask and it is difficult to control things. Next, please. So, ideally, pregnant COVID-19 inpatients should be cared for in a specially equipped single patient rooms in all three stages of her care. That is antepartum, intrapartum, and postpartum. And these should be COVID-19 only units. Like in Shifa, we have had allocated separate floors for these women. And preferably, these should be negative pressure rooms. It is not always possible to have negative pressure rooms, but if possible, that should be a gold standard. Pregnant patients with suspected or confirmed COVID-19 are instructed to wear a surgical mask during labor and delivery. Again, it is difficult to make them to adhere to this because of during the active pushing phase. And that's the time when the risk of droplet generation is greatest. Next, please. Can we get the slide on the full screen, please? So, most units, I'm not sure about Pakistan, but in most units, there is one support person is allowed with the laboring women. And actually, it is recommended. But if it is the policy of any facility, then one should make sure that that person does not leave room and then return. So it should stay in the room. The support person should be screened for fever and other symptoms before entering the building and in accordance with your hospital's policies. So these support person could be the patient's husband, patient's friend, patient's mother, sister, etc. So in the New York City pandemic, 199 support persons were screened, and they found that 20% were positive. So it is very important to screen the support person as well if you have a policy of allowing them in with the laboring mother. So those with symptoms consistent with COVID-19 exposure or exposure to a confirmed case within 14 days or a positive test of COVID-19 within 14 days should not be allowed to attend the labor and birth. And if screen negative, of course, a face mask should be worn at all times. Next, please. Next, please. So, route of delivery. COVID-19 is not an indication to alter the route of delivery. So, in other words, one should not resort to cesarean section just because a woman has COVID-19. Cesarean section is performed because of the standard obstetric indication, which is your failure to progress, fetal distress, previous to cesarean, etc., etc. But at times it is also indicated whenever the mother is decompensated because of COVID-19. Because vertical transmission is not confirmed, hence cesarean section is not indicated or not recommended in COVID positive mother, because we all know that the cesarean section inflicts maternal injury because it's a surgical procedure, the recovery time is greater, the risk of, with cesarean section, there's more risk of hemorrhage, infection, thromboembolism. So it has added risks. And furthermore, it is unlikely to improve the outcome of the newborn baby. Again, it is encouraging to know, and it is consoling to know that the reports on COVID-19 infection in the neonates, in the babies, are generally described as a mild disease. So this is again a good news. So there's no need to unnecessarily inflict injury to mothers by delivering them by cesarean section. Next slide, please. So whenever you're screening patients for who are scheduled for induction of labor or cesarean section, it is best to screen them the day before, within the 24 hours. At times, 48 hours is also acceptable, but most hospitals would go for 24 hours. If the patient is symptomatic of COVID-19, it is feasible to reschedule until the procedure, until the COVID-19 test is available. So once the COVID-19 test is available, and if it is negative, then you go ahead with the procedure. But if it is positive, and then you have to balance the risk of delaying and the risk of going ahead with the induction of labor and cesarean section. And that is something that the treating physician or consultant has to make that decision. It is generally felt that it is better to deliver them if they are having relatively less symptoms or no symptoms than to wait, and in case the disease gets much severe, and then the delivery will become more complicated and the baby will be adversely affected. So it is a difficult balance to strike, but it is a senior decision. Consultant has to make that decision. So in asymptomatic women, inductions of labor and cesarean section should not be postponed beyond 39 weeks, or for cesarean section especially, and after counseling the patient. Next, please. So with regard to analgesia and anesthesia, the neuraxial anesthetic, which is spinal and epidural, is not contraindicated and actually has quite a few advantages. So first of all, it provides good analgesia, hence reduces the cardiopulmonary stress from pain and anxiety. And because it is not aerosol generating procedure, it reduces the risk of viral dissemination to the healthcare professionals. Additionally, it is in a laboring woman, it is if epidural is in place and for any reason cesarean section is required, it obviates, it reduces the chance of that woman getting general anesthetic. So the the epidural can be topped up and a cesarean section can be carried out. However, the units who are using nitrous oxide or Entonox for laboring mothers, the data is insufficient, but the CDC recommends that it is perhaps better not to use it because of difficulty in cleaning, filtering, and the potential aerosol generation in these with nitrous oxide. General anesthetic, which is during intubation and extubation, is a quite profound cause of viral spread, because at this stage aerosols are generated and it is a aerosol generating procedure. So the healthcare professional involved in general anesthetic should wear special PPEs, which is covering your face, eyes, goggles, and masks, etc., and gowns. Next, please. Next slide, please. So magnesium sulfate. So we know magnesium sulfate is given in pregnancy. We give it to prevent seizures in women in suspected cases of severe in cases of severe preeclampsia and eclampsia, and also we give it for neuroprotection in preterm or suspected preterm birth. Magnesium sulfate suppresses a respiratory system, and if a woman has respiratory compromise, then it should perhaps be avoided if possible. So it should be discussed and treated on a case-to-case basis. But if there is no respiratory compromise and you think that the benefit of magnesium sulfate outweigh its risks, then definitely it can be used. Next slide, please. So how do you manage labor? Labor is not, the management is not altered in cases of confirmed or suspected cases who are asymptomatic or has mild symptoms. But the person-to-person contact should be limited as safely as it is feasible. And it is recommended that the ripening stage, when you're doing induction of labor, for cervical ripening, the woman could be given a balloon catheter to be used at home as a mechanical ripening agent. And for inpatient cervical ripening, one can use two methods, for instance, prostaglandin and mechanical ripening, or mechanical, for instance, balloon and oxytocin, which actually decreases the time from induction to the time to delivery. Continuous electronic fetal monitoring is recommended with suspected or confirmed COVID-19 cases, because there is increased frequency of non-reassuring or abnormal CTG traces in COVID-19 patients, and especially in women who have pneumonia and have a severe illness. Intake and output of fluids should be monitored in these women, as aggressive hydration should be avoided because it can lead to pulmonary edema and further worsen maternal oxygenation in women who are already compromised. So the total fluid should be somewhere around 75 or even less per hour. Next slide. Next slide, please. So artificial rupture of membrane and internal fetal heart rate monitoring may be performed, as SARS-CoV-2 has rarely been detected in vaginal secretions or amniotic fluid. Now, in Pakistan, we are not doing internal fetal heart rate monitoring, but artificial rupture of membranes can be performed. It has been shown that the feces carries the virus. In 26% of the fecal matter in COVID positive patients have found to have carried the COVID. Sorry, I got disconnected because of the phone call. So yeah, so the feces does. There's a 26% there's 26% risk of having COVID-19 virus in the feces, and we all know that during the second phase of the second stage of the labor, a significant proportion of women will have past feces and can cause a risk to the healthcare professional. Water births are not popular in this country, but they are gaining a lot of popularity in the West, and they are potential cause of risk disease transmission, hence avoided. Again, I don't see many women using birth ball or peanut ball. It should be avoided because of risk of infection, and furthermore, it has no proven benefit in reducing the pain to the mother or enhancing the labor process. So it should be avoided because it's a balloon thing and it's very difficult to clean it between patients. Next, please. So maternal oxygen therapy for fetal resuscitation should be avoided as it has no proven fetal benefit. Because whenever there's fetal distress, some people use oxygen. There is no evidence that it improves the oxygenation of the baby, so it should not be used. Nasal cannula and face masks come in contact with maternal respiratory tract secretion, so handling of such equipment can further increase the risk of contamination and exposure between patients and the healthcare provider. And the other thing that is recommended in these COVID positive patients during labor is that do not delay pushing in the second stage. So instead of delaying pushing, encourage to have early pushing as soon as the cervix is fully dilated. And you can even assist delivery and minimize the duration of active pushing, because the deep breathing and expulsive efforts during the second stage may risk the healthcare providers because of the aerosol spread. Next slide, please. So it is generally recommended that the umbilical cord should be delayed so that the risk of fetal anemia is less and there is less risk of other problems in babies. So, but in this case, the delayed umbilical cord clamping is highly unlikely to increase the risk of transmitting pathogens from an infected mother to the fetus. So it is still recommended that one should continue with this practice. And Dr. Rizwana Chaudri has elaborated on breastfeeding. So skin-to-skin care and breastfeeding is recommended as long as the mother has the surgical mask on and proper hand hygiene is practiced. I don't know if you've heard of umbilical cord banking. It is used quite frequently in the West, whereby mothers leave the cord blood for stem cell use in future if required. A couple of my patients here in Shifa have requested it, and there is an organization that arranges it. So this can be done even in the COVID-19 positive status, because we know cord blood does not carry COVID-19. So you can still carry on with umbilical cord blood banking. Next, please. So again, the drugs have been mentioned that remdesivir is the antiviral drug, and infants are not likely to absorb clinically important amounts of the drug from the breast milk. And no serious adverse effects have been seen in the newborn infants from the experience with use of remdesivir in Ebola in Congo and African countries. So it is considered safe. Next slide, please. So with regards to the analgesia after cesarean or delivery, so non-steroidal anti-inflammatory drugs are commonly used for the treatment of postpartum pain. However, some concern was raised about possible negative effect of non-steroidal anti-inflammatory drugs such as brufen, diclofenac in patients with COVID-19. But this was only based on some anecdotal reports of a few young non-pregnant patients who received the ibuprofen, and they had a worsening of the course of infection and experienced more severe disease. However, there have been no clinical or population-based data that directly address the risk of NSAIDs. Therefore, given the absence of data, NSAIDs may be prescribed when clinically indicated. So your preferable analgesia should be paracetamol, but if required, NSAIDs may be prescribed. And if NSAIDs are required, then they should be used in the lowest effective dose and for the shortest duration of the time. Next slide, please. So discharge from hospital. Early postpartum discharge is recommended to limit patients' personal risk in hospital environment. So whether the patient is COVID or non-COVID, it is better if she's well, she should be discharged early. Next, please. So how would you organize a postpartum follow-up visit? So modifying or reducing postpartum outpatient care is appropriate to reduce the risk of inadvertent exposure. Therefore, it may be possible to have a postpartum follow-up visit via telemedicine. Postpartum follow-up visits are nearly becoming obsolete in West anyways, because they have a very good system of midwife visiting the new mothers at home and looking after them. So usually if postpartum care is done, it's usually done by their general practitioner or their family physician, but it is rarely being performed in the tertiary care center. But only, yes, if it is required, then it should be performed, but via telemedicine. Next slide, please. So this is, I've taken some shots from our hospital. So this is our nurses station in Shifa Hospital. So our doctors are wearing their protective gear. So the left side of this, where you can see the curtains, these are the patients who are COVID negative. And the one on the right, we don't know their status, are on the right side. COVID positives have a separate ward, so they don't come here. They only come when there is when they are in labor, or they need to be actively managed on the labor ward. So one of our labor ward has negative pressure, so they go there straight. Next slide, please. Again, the same. So doctors and nurses wearing their protective gear. Next slide. So a doctor, a nurse looking after a COVID positive patient. Next slide, please. Next. So yes, this is an interesting slide I wanted to share with you. So what we've done, this is a negative pressure room. This is a labor room. And can you see there is a little partition? It's like a polythene kind of or a plastic sheet in front of, between the patient and the healthcare providers. So, the direct impact of the aerosols may be to some extent is reduced with this. Next slide, please. So that's the baby. We don't separate the babies from the mothers. So that's the babies handed to the mother. Next slide, please. And is being breastfed. Next slide, please. Yes. So this is our operating theater. So we have allocated a donning area. This used to be a recovery area, but we have another recovery area. So this particular recovery area we use as a donning area. So we go in, we've got sanitizers, we've got the hazmat suits, we've got masks already we are wearing, and we have got gowns and head covers and goggles, etc. So that's where we don the PPEs. Next slide, please. Yeah, that's the inside of the room. So we've got things, and we've got long boots at the bottom. So that is OR3. This is room 3. This is the entry to. This is the first double door, and from the red marked area, nobody else goes in apart from the ones who are fully donned. And then to the next slide, please. Next slide, please. Yeah, so now we're entering the operating room. Next slide. So this is a surgery taking place. As you can see, the anesthetists at the back are fully on their hazmat suits, and so are our physicians and doctors. Next. From another angle. Next slide, please. So this is our doffing area. This is the area immediately out of the room. So that is where we doff our gowns, and so there's two yellow bins, and then from there we make an exit. Next slide, please. So this is our COVID ward. These are where antenatal and postnatal patients are housed. So our women are in their separate rooms. The nurses, they go in on a need to go basis. So they sit outside rather than sitting inside the room. They're sitting outside. So they are immediately available. So they go for their routine rounds. The doctor can go for their routine rounds, but the nurse is allocated to a particular room, and they're sitting outside, and they do their vitals on the patients, check on them, and the doctors do their routine rounds. So in no way they are left alone because they are COVID positive. They are looked at exactly the same way, and in fact, a little bit more, carefully and than the non-COVID patient. Next slide, please. So this is again the same ward. Next slide. So this is our labor and delivery area. Can we move to the next slide, please? Is this a video? If it's a video, can you play it? So now we are entering the labor ward. This is the reception area. Okay, security check. The patient is cleaning her hands. So this is the triage room. So now the COVID results are awaiting, and she can be shifted in one of these rooms on the left. And so this is a COVID negative patient area. There's a patient is coming in. Mind you, this is a dummy patient. This is not. This is one of the staff pretending to be a patient. So this is a negative pressure delivery room. We had shown the pictures earlier. She's being wheeled into the room. So now this patient has developed fetal distress and we're taking her to the operating room. So this is the operating room 3 has been made during the COVID days into a negative pressure operating room. So the doffing, we're entering the donning area. We're wearing the required PPEs. We're coming out now. We are now entering the labor room. The patient is already there. The operating room. This is the doffing area I mentioned. We scrub here. So this is the negative pressure operating room. Surgery is carried out here. You have a nice view of the outside. So don't feel so claustrophobic, despite wearing the hazmat suits, which are actually quite claustrophobic. And in one thing in negative pressure rooms, you cannot maintain a low temperature because there is a connection with the outside, and with temperatures of 40 and 45, it's very difficult to maintain a good temperature. And with the hazmat suit on and the mask and all the headgears and whatnot, one is after the procedure, you're drenched from head to toe in sweat. And and we, after performing the procedure, we all the healthcare professions are instructed to have a shower before they and change into new clothes before they deal with other patient or head home. Is that the end? Thank you very much. Oh, have we restarted it? I think this is the recommencement. Thank you.
Thank you for sharing such valuable information with us, Pam. This was a very insightful and comprehensive session. If it's all right with you, can we begin our questions and answer session now?
Yes, I can. Yes, go ahead.
Can you hear me, ma'am? Okay. So I'll be asking you some questions now from the participants. The first question that we got is that what is the reason for a higher percentage of ICU admission and intubation in pregnant women as compared to non-pregnant women?
That is a very good question. So as we know that a pregnant woman has some physiological changes that are taking place in her, which is, we talked about hypercoagulability plus low immunity. So pregnancy is a low immune status. So you are more likely to get more severely affected by the disease. And that is the reason, and it has been shown now by the statistics. So that's why the CDC has changed their recommendation that it is no longer, we don't have the same risk as a non-pregnant patient. We actually have a more risk especially in advanced pregnancy, of acquiring a more severe form of illness. So if you read the recent literature, actually published within the last week, actually, you'll find that the whole recommendation, the UCOS had already said that, but the CDC has now followed suit, and they are also recommending that pregnancy is a high risk status for COVID-19.
Okay, thank you, ma'am. The next question is that are there any side effects of giving low molecular weight heparin during pregnancy and also after delivery?
So let me tell you that low molecular weight heparin is regularly given to pregnant women and in the postpartum period. So actually it is recommended, the risk of developing, so forget about COVID-19. COVID-19 can cause coagulation, but pregnancy itself can cause coagulation. So when you compare a pregnant to a non-pregnant woman, her risk of developing thromboembolism is much more than the non-pregnant women. So all my pregnant patients, when they are admitted, even before the pandemic, they would receive low molecular weight heparin. But if they had risk of a prior DVT or a family risk, or they were relatively immobile, or they had other comorbids like obesity and diabetes and other risk factors, then even in pregnancy they would receive the low molecular weight heparin. So low molecular weight heparin does not cross the placenta and is very safe in pregnancy and postpartum period, and actually recommended. And it is highly recommended in case of COVID-19 in pregnancy.
Okay. Thank you so much, ma'am. The next question we have is that you mentioned that there was an increase in the percentage of mental health problems in pregnant patients who are COVID positive. So how should we address this increased level of anxiety and other mental health problems in pregnant women who are suffering from COVID-19?
So to be honest, I don't have the right answer, because there's no right or wrong answer to that. You cannot change the fact that we have this pandemic, and then women are isolated, women have financial problems, women are stuck in, with some, well, in the Western culture with the nuclear families, there's an element of loneliness. And in Pakistan with a joint family living, they are stuck with the family that they may not get along very well with, their in-laws and blah, blah, blah. So it's a very difficult question to answer, because we cannot change the social setup, we cannot change what we are struck with pandemic. But what I would recommend in this case is that we can have more contact with patients. Somebody mentioned family physicians, so they have a role to play. We don't have that system in place in Pakistan, so the onus is on us. So telemedicine is a very good way of contacting patients, and I find when I would have a session with them, they would feel much calmer and much relaxed, and would actually verbalize. They'd be very vocal about it, that they felt now more content and relieved after having a session with us. But the unfortunate thing is that the vast majority of people don't have access to internet. They don't have access to your smartphones. So what do you do about them? And that is, I have no answer to that. So this is a wider question that has to be addressed at a broader level, maybe at a government level, and by these organizations who should address these women who are stuck in their homes and have no access and recourse to healthcare facilities.
I think earlier we also mentioned the role of helplines and how beneficial they could be in such cases. I think the government should definitely look into that as a potential solution.
Yeah. So organizations as well. Yeah.
Exactly. So the next question, it's kind of budding off the same topic, is that was there any observable increase in postpartum depression and psychosis during the last 3 to 4 months?
In my practice, I haven't seen psychosis, but I've certainly seen depression, and in both in antenatal and postnatal period, and that's not denying it. And it has been proven that women have had the domestic abuse has increased, the mental health issues has increased. Shifa had introduced sessions for counseling for healthcare professionals because they were getting stressed, and so we had some and group sessions that should have been done on a larger scale for our patients, but it is a difficult area. Even in the best best of times, it's a difficult area to address. But in this situation, it's even more difficult.
Yeah, agreed. Yes. The next question is that, is screening of a patient before labor and delivery enough, or should we go for PCR testing?
Oh, we do pre-PCR testing. In Shifa, this was a policy. We would do PCR testing. And of course, we would also do symptomatic screening and history of contact with the COVID positive patient in the last 14 days.
Right, okay.
Yeah.
Then the next question is, does COVID increase the risk of HELP syndrome?
Does COVID increase the risk of HELP syndrome? I haven't had any statistics about that, and I haven't seen any. So it is not documented.
Okay. The next question is that, have any differences been noted in the rates of postpartum hemorrhage with COVID positive patients versus the ones who don't have it?
No, I haven't seen it, and there's no documentation about that. There's no evidence out there.
Right. Fahad is asking, how do you suggest we should plan to cater the increased burden of upcoming births, which are attributable to the lockdown?
Oh, very interesting question. Very interesting. So we are expecting a baby boom, 9 months from now, 8 to 9 months from now. So the way I looked at things, and most of my colleagues agreed with this strategy, that it is so funny that even in the height of epidemic, women would come for infertility treatment. So I would tell them, please hold on. You've held on for so long. This is not the time to get pregnant, because pregnancy, as Dr. Rizwana Chaudri highlighted, can lead to miscarriage, can lead to ectopic pregnancy, can have other hyperemesis. And so why subject yourself to a condition which will lead you to a hospital? So avoid hospital if you can. So the simple answer is that avoid pregnancy. That was my advice to my patients. And I'm sure my contemporaries would have done the same. But if families are living together, couples are together, it's nearly inevitable. It's nearly inevitable that more pregnancies would have taken place. And how do you stop it? You tell me. I have no answer.
Absolutely, I think.
If you see them, of course, you advise them, but there'll be so many people who will not even bother to seek advice.
Yeah, I think there should be more of an emphasis on general public awareness in any form.
Yeah,
that it can be.
Yeah, my problem is that when you look at the morning shows there's a multitude of channels, and when you see they talk about weddings and cooking, and these are the kind of information that they should be spreading out, and there's a total lack and awareness in our public about these things. So I would have liked that people should have come on the telly, and telly is something that was very much I think the viewership increased remarkably during COVID days, because that's what they would go, because cinemas were closed. You wouldn't go out to restaurants. People would be stuck at home and they'd watch movies, and Netflix subscriptions have gone up like crazy. And but this is, I think, educational sessions should have taken place during this time rather than cooking and bridals and that kind of stuff.
Definitely, yes. So the next question by Dr. Farooq is that, is additional anticoagulation needed for COVID positive pregnant patients if they're already on heparin for autoimmune conditions like antiphospholipid syndrome?
So that should cover whenever we give anticoagulant, we give it to make the blood thinner. So that should be enough to cater for the needs of COVID-19 risk of hypercoagulability. One shouldn't increase the risk, because that can lead to the risk of hemorrhage.
Okay. The next one is that, does analgesia have any adverse effect on the respiratory effort of a COVID positive patient?
Actually, analgesia has a beneficial effect on the respiratory risk. So if you are stressed, you're in pain, you're hyperventilating, and it can adversely affect your lung function. So analgesia has a calming effect on the mother. It is the beneficial effect on the mother, and it should be given generously.
Okay. The next question is that, has proning been used for pregnant patients, and are there any guidelines for this? Does it have any adverse effects? it would be difficult for pregnant patients also to prone.
So in early pregnancy, proning should be fine, but in late pregnancy, it probably is difficult. But there are situations where one can put a little pillow on one side and move the chest, because it's a chest proning. You want to get the oxygenation to the posterior of your lungs. So that is possibly, is perhaps possible, and should be done as much as possible on both sides. So if you can do semi-prone position rather than full prone. So that is possible with heavily pregnant patients. But in early pregnancy, in up to 20, 24 weeks, it shouldn't be a problem.
Okay. The next one is that during the 2009 H1N1 flu epidemic in 2009 in the US, pregnant women accounted for about 5% of total deaths, whereas only 1% of total population were infected. So do you believe that similar stats will be reported as data is collected for this part of the world?
Okay, so now that was a flu virus, and it had more predilection for pregnant women. So in my early slides, I mentioned that the predilection to the pregnant women is the same with the COVID. So it is behaving slightly differently. So let me give you an example. So if a pregnant woman and a non-pregnant woman with the same kind of a profile is exposed to the virus, both of them are have equal likelihood of acquiring the disease. But in the pregnant woman, especially in late pregnancy, it is more likely that she'll be hospitalized, that she'll be ventilated. So this is the risk that is increased in late pregnancy. Whereas H1N1, if a pregnant woman and a non-pregnant woman is there, the pregnant woman is more likely to get the disease. So then vaccinations were available. So we were giving, during the flu season, we were giving those vaccinations to the mothers to prevent them from getting the infection. But here we haven't even developed the vaccine yet.
Not so far. All right. So the next question is that a New York hospital study reported COVID positive pregnant women have 13% chances of readmissions after delivery as compared to 4.5% in COVID negative patients. Have we observed a similar sort of trend in our population?
In Shifa, we haven't. Actually, we've been lucky. We have had a lot of patients. I've delivered a lot of COVID positive patients and done cesareans on them. But either we were lucky, or the kind of population that we get, these are probably more socioeconomically, they're better off because it's a private hospital. They're probably more educated, so they know how to look up. But this the question should be asked from Dr. Rizwana Chaudri, because I don't know whether Dr. Saba is working for the government hospital now or not, but I am not sure what the situation was in the government. But overall, I think we've been extremely lucky in Pakistan. We haven't had the same brunt of the disease as the other countries, the Western countries. And the worst was actually America, believe it or not, and UK. With all the top-notch healthcare facilities available, and so I think God has been kind to us.
Yeah, definitely. I think the other countries have it a lot worse than Pakistan.
We haven't seen severe cases, to a large extent in pregnant patients.
Mm-hmm, mm-hmm. Right. So next question is, what kind of breathing exercises or room activities would you suggest for pregnant patients?
Well, to be honest, pregnant patients should behave as much normal as possible. That's my standard thing to all pregnant women. No need for deep breathing exercise. Yes, in labor, to alleviate the pain, yes, they have to do deep breathing exercise. But that is some during labor. But normally, just behave as normally as possible. A pregnant woman body is physiological and psychologically geared to deal with pregnancy. Of course, it gets that added stress when a disease is inflicted on this pregnant woman. But by and large, no need to do any special breathing exercises. I know these are a lot of lay public has made up a lot of things, but there's no scientific evidence to support that. Like even drinking certain kavas and certain herbs and certain doing certain exercises, but there is no scientific evidence to support that.
Okay. We've got a question which says, have any congenital anomalies and miscarriages been linked to coronavirus as yet?
No, not yet. We haven't
Not yet.
had excess of miscarriages, and we haven't had congenital anomalies with coronavirus.
Okay. Is there any data that tells us about transmission of COVID-19 from a COVID positive mother to her neonate? And what is the survival rate for neonates who have contracted the virus?
The good news is that the neonates are lucky to have a mild disease only. So they are at a benefit. That's why we have encouraged them to be housed with the mother, to be roomed in, and to be breastfed by the mother. If there were any case reports that suggested that the babies are worse off with the infection, then we would have separated them. So that's not the case. So we haven't got any adverse effect of corona positivity from the mother. We don't have the data how many get affected by the coronavirus from the mother, but certainly even if they do, they get a very mild disease, and they don't get badly affected. But I think this is something that whenever you have do you have any session with the pediatricians and neonatologists?
Yes, we do.
So this is the question, put it to them.
Okay.
Yeah.
We will make sure to ask that in that session.
Yeah.
So Ms. Lubna Miraj is asking, do we have data of COVID positive pregnant women and the complications in the Pakistani population?
You're a very interesting question. I keep asking. We have this CDC figures. UCOS is a glowing example of it's a success story. Actually, the problem is that the rare diseases are very difficult to research because they're rare. And pandemics, again, because it's a rare pandemic, it has never happened before. So these are very difficult conditions to study. Now, Pakistan has started few studies, but on a smaller scales, like individual hospitals, but we don't have a nationwide approach to these problems. When will this happen? I've heard, and it's that we may have a CDC kind of setup in the NIH, and hopefully it'll happen soon. And then we will have, if we have these rare diseases, and we'll see how the disease behaves with Pakistani population, with our demography, how does it affect, then we can study these conditions, and then we can work out a management plan, a treatment plan, a prevention plan, a service delivery plan. But up until that time, we have to believe what the world is telling us and our own anecdotal experience. So we don't have a nationwide surveillance system, a study system, a research system, whereby we can study these conditions. Because we have seen COVID-19 has affected Western population differently than us in Pakistan. It has affected the BAME population, the Black, the Asian, the ethnic minorities, at worse, they were worse off compared to the white. And in America, the Hispanic, the Blacks were again worse off. So it is variable how a certain disease affects a certain ethnic group.
All right, thank you, ma'am. Unfortunately, we have to move to our last question now, which is that workplaces are opening full time. So do you have any advice for pregnant women who will be returning back to their jobs?
Very good question. So first of all, I think it's the responsibility of the organization. So to look into the safety of their workers. So there are few plans in place by certain work organizations. So some are actually, if they can, they are totally, work is being done from home. And very good work is done. Like some businesses have actually flourished in the pandemic, despite the fact that their offices were closed. And then there are other businesses, what they're doing is their office setup is such like there's a safety distance of 6 feet or 2 meters. And so they have reorganized their work setup. There are others that they have done a kind of a shift work. So the 50% of the workforce will come for 2 weeks, and the other 50% will come in the next 2 weeks. So there are different models that can be adopted. So for Shifa, what we did in the pandemic, we because the elective work was reduced, so the highest specialties like ENT and anesthesia, because there were not many cases going on surgically. So all the older consultants and professionals, healthcare workers, and the ones who had comorbids, severe comorbids, they were told to stay at home. So it was like a compulsory holiday. Okay. What we did with our postgraduate trainees and our medical officer junior staff, because again there was not much work, we got them to work for a week and be off for a week. So one group would work for a week and the other group would be off. So the one who was working, if they developed symptoms in the first 5 days, we would know that they have developed symptoms. So we would then screen them, get them to be tested for COVID, and then I'm sorry, whenever I get a phone call, I get blocked from the session, so I've just turned it off. So what?
It's not a problem.
So what that's why we manage. So this actually happened. Some of our junior staff did develop symptoms, and we got them to get tested, and they were positive. We got them to stay at home. So that worked extremely well. So now what we are doing, now that everything is open and the patients are coming back, in leaps and bounds. So what we are doing, so in our clinics, we have, we used to have our examining. I wish I could have taken pictures of that. So we have examination couch in my room. So I would do my history and then examine the patient. So not been doing that. We have allocated, mom would know because she knows the setup. So these are, those history, we used to take histories and all, so put in couches there. So we go there. So if my patient comes and I talk to her, and in front of my desk, there is a screen. You must have seen Shaheen and other, they have put up these screens, these plastic or glass shields. So we talk through that. But I don't examine them because you're prolonging the time period of the patient in the room with you. The other thing, I believe in confidentiality, but here I now keep my door open. So the circulation, I don't keep the door of my office closed during assessment. The third thing is, so I have my mask on and I'm behind the screen and I'm talking to her, taking my history data, blah, blah, blah. But if I need to examine her, I take her to she's taken to the examination room, and then I put on my gown, I put on my gloves, obviously. Sometimes I put on my head cover, but not always. So we do there. Then I go, because now I'm in close contact. Gynecological examination you're in close contact with the patient. So then I do that, and then I come out, and then if I need to talk to her again, I get her to come back. We also had a hybrid kind of a setup. In hybrid setup, what we had screens in those rooms that was in the height of the pandemic, and these are patients who we wanted to be seen in the hospital and not just the telemedicine. So in the hybrid setup, the women would come in the hybrid room, and we would in a room, and it had a screen. So through my laptop, I would talk to her on video, probably even next door to that woman, and talk to her and take her history. If I needed to examine her, the couch would be there. I'd put on my protective gear and go and examine her. So that hybrid things was being done. But now we are all face-to-face sessions, but examination is done in a separate room. So I only go and physically get in touch with the patient when I'm fully covered. So that's how we have modified our. And I think some of these work practices are going to carry on. So for instance, like we often do the urine culture or high vaginal swab, and the result comes back 3, 4, 5 days later. So so it comes back, and then there's no point the patient comes to the clinic for that. So, or even some results or biopsy, we can discuss after doing the procedure. We can discuss the procedure on telemedicine or on telephone. So this is something that we have to carry on. Furthermore, if a patient needed hysteroscopy, endometrial biopsy, so instead of taking her to theater, exposing her to my healthcare professionals, the anesthetist, to the risk of aerosol, I would just do a pipelle biopsy in office to prevent that additional risk. So these are the kind of precautions we took during this session. So it is all about modification. Of course, the organization will have to pay extra to protect their staff and to keep their businesses going. So it is added burden on the organization, but I think this is the demand of the day, the call of the day, and has to be done.
Okay. Yeah. So we've just received one more question from Ms. Ayman Ali. She's asking, is there any data showing proof of antibodies against COVID in neonates born to mothers who have recently recovered from COVID?
Again, a good question. And I think because these are evolving statistics, it is best to ask a neonate. Because IgG antibodies can be transmitted to the babies, through breast milk and through the placenta. But whether they actually prevent infection, that's a totally different question. So we have no answer, not to me. I don't know if there's a very recent article on that has elaborated that risk, but to my knowledge, it is still an area that is not fully answered. But do ask your neonatal, your lecturer to elaborate on this subject.
Of course, we will follow up on that. Okay, so that concludes our question and answer session. Thank you, ma'am, for taking the time to answer all our questions with so much detail. And thank you once again for joining us today. It was an honor for me personally, and I'm sure Maham also felt honored by your presence today. So we just like to thank you once again.
The pleasure was all mine. It was lovely to have worked with Maham. And also, I think it's a great opportunity, and you provided opportunity to students, to other doctors, to healthcare professionals, to take benefit from our experience, from others, and in all specialties. So thank you all very much.
All right, thank you, Dr. Shahnaz. Over to you, Dr. Maham.
Thank you, Dr. Shahnaz. It was a lovely presentation, and obviously an honor for me because since you've been my professor, just having to host this for you has been especially an honor for me. This concludes our session for tonight. I would like to thank both Dr. Rizwana and Dr. Shahnaz for giving us their time and valuable information and sharing invaluable experiences with us. Thank you to the participants for joining us. We hope that you have gained as much as we have through this session. Please do not forget to fill the feedback forms, as certificates will be distributed based on that. Thank you to Ibrahim for being such an amazing co-host, and the rest of the team for helping us conduct this session. Our next session is going to be tomorrow, same time, same virtual space, and we will be discussing dermatological and ophthalmological concerns related to COVID. Our speakers include Professor Fareedur Rahman, who's the head of dermatology department at Foundation University Medical College, Fauci Foundation Hospital, Rawalpindi. And the ophthalmological session is going to be conducted by Brigadier Taimur, who is the general ophthalmologist at Al Shifa Eye Trust Hospital, and Dr. Hina, who's responsible for medical retina and diagnostics at Amanat Eye Hospital, Islamabad, and Rawalpindi. So I hope to see all of you tomorrow. Same time, same virtual space. That's all from my side. Ibrahim, over to you.
Thank you so much, Dr. Maham. For hosting with you. Thank you once again to our speakers for sharing such beneficial information and taking time out to increase our knowledge. Thank you so much to all the participants for tuning in. A special appreciation for Professor Samia for all your efforts. She is our patron as well as our advisor for the academic team. and these series would not have been possible without her. Thank you, Dr. Sabah Akhtar, co-founder of VFP and also the advisor for our academic team. She has been the backbone of our team. Thank you, Mr. Iftikhar Yazdani, CEO of Rahe Kamar and a partner of VFP. His company provides voluntary IT services for this noble cause. Thank you, Dr. Rabil Tariq, co-founder of VFP. Thank you, Dr. Mavish, co-director of the academic wing of VFP, Dr. Pinar and Dr. Fahad, and many others for supporting us throughout the session. Thank you on behalf of Team VFP, Team Yardim, and Team RMU. Allah Hafiz.